First speaker is no other than NISCHAL. He's Advances in Management of Corneal Opacity from US. Please. Can we have the slides up, please?
They're up. Perfect. Thank you very much for inviting me to speak in this session. Okay, so how many people in the audience manage corneal opacities in children? And that's even just seeing them. Susan, put your hand up. These are my financial disclosures. None of them are relevant to the talk. So Peters anomaly, I've been saying this for a long time, actually now about 26 years. It's a bad term. This is a picture of a child who was thought to have sclerocornea. When you do the UBM, the lens is attached to the cornea. That's supposed to be Peters anomaly type 2. So which is it, sclerocornea or Peters anomaly? As a result of that work that started when I was a fellow, I came up with a new classification, and the classification is this. Basically, there's primary corneal disease and there's secondary corneal disease, right? Primary corneal disease, the only things that are primary corneal disease are corneal dystrophies, corneal structural defects due to dermoids, and this condition called CYP1B1 cytopathy. I'm not really going to talk about that very much, except that in certain cases of congenital glaucoma, you don't have Harb's-Tree, but you have a hazy cornea. You control the glaucoma, the cornea remains hazy. This is called CYP1B1 cytopathy, and it's been published a lot. And then I'm going to talk about the secondary corneal diseases, and we'll get through them. It's important that secondary corneal diseases are developmental or they're acquired, right? So it becomes a logical step as to how you approach congenital corneal opacities. This is the algorithm I use to decide how to manage a child that presents with congenital corneal opacity. They get a clinical evaluation, and I rely on electrodiagnostics, and then they also get a systemic evaluation, and if possible, if it's available, I do genetics. I want you to note that sometimes you cannot do anything, either because of the family circumstances, or because of the child's illness, or because of the severity of the condition. But otherwise, there's a whole range of things that I'm going to talk to you about that you can do. Here I've put first that you must manage the glaucoma. If you do anything without managing any secondary glaucoma, it's going to fail. So let's go through the different things that we can do. This is a child who, I'm showing you this because I have a very good video, but basically the child had had congenital cataract surgery, congenital glaucoma surgery, and had a decompensated cornea. So because I have integrated intraoperative OCT, I was able to do a DSEC. And what you're seeing here is that I used a pull-through technique with a suture, and the endothelial graft is hanging there at the moment. And what I'm going to do is I'm going to inflate the eye with air. Now, the way I do these cases, I do the inflation, I make sure there's apposition. The child then goes into the recovery for about 2 hours, still sedated, then comes back into the OR so I can check the pressure and check that the endothelial graft is opposed. You see that is total apposition. In children, you do not need very thin material because over a period of 6 to 8 weeks, the endothelial graft thins. So it's quite difficult to do a DMEC in children, but this is about 100 to 120 micron DSEC. Now, this is done. Child goes into recovery, comes back, pressure was good, I'm happy, child goes away. This is exactly 6 weeks later. You do not need to do a penetrating keratoplasty when the stroma is clear and the problem is the endothelium. All right, so DSEC. What about deep anterior lamellar keratoplasty? I published about this the first time 15 years ago. You can tell that I'm getting old because everything is in decades, not a couple of years. And what we talked about was the use of DALC in mucopolysaccharidoses. Now, if you are in a region of the world where you cannot do enzyme replacement or bone marrow transplant, then it's better to do a PK. Why? Because the endothelium becomes damaged if the children have not had a bone marrow transplant or are not on enzyme replacement therapy. But if they are, then a DALC is much better. And here, what I want to show you is that there's a double layer here. The first layer is Dua's pre-decime layer, and it's very easily viewed in children. And sometimes I have to use the OCT because the separation is not perfect, But here afterwards, you can see that I've put the DALC on, and this is what it looks like at the end, and it's really quite remarkable. This is just to show you that if you get right down to decimase, you get a really good result. It's as good as doing a PK, but much safer. All right, so we've talked about DSEC, we've talked about DALC. What about other conditions? So here's one that actually Parth Shah, my ex-fellow, showed in the other room. If you have a very large dermoid, right, people worry about having to do a lamellar keratoplasty. As long as the bed of the dermoid is no more than 250 microns, then we've published this technique. And the technique basically, I'm going to talk you through it, is in A, on the top left, in A to D, A, B, C, D, what we're doing is we're taking away the lipodermoid. Once you take that away, you close the conj, let the child recover. 6 weeks later, you come back, you take the corneal dermoid off, and then you do an SLET. How many people know what an SLET is? So it's a simple limbal epithelial transplant. You take a 2 by 2 millimeter straddle across the limbus, which is shown up in this one here, and then you cut that 2 by 2 into 8 pieces. That's the most difficult bit. Then you place those pieces with the corneal part towards the center on the bed with glue, and then you can either put amniotic membrane or a bandage contact lens, and look what happens. The recovery is remarkable, and you get some stromal regeneration as well as epithelial. So you do not need a lamellar keratoplasty. So if you're in a part of the world where getting tissue is difficult, you can do this. But if it's more than 250 microns, you will get ectasia. If it's 250 or less, this girl was done 11 years ago, she's developed no ectasia. So sometimes it's better to do it and then come back later when you've got material to strengthen that area. Okay, and that's what, again, what it looks like. And I've now resorted to using this technique even in simple limbal removal because I get no scarring or very little scarring. Okay. I don't have a timer here. I hope I'm okay for time. They're not, okay. So now let's talk about what people call Peters anomaly. Sorry. I have a reaction to that term because if I say Peters anomaly, let's say to the gentleman at the front, what is Peters anomaly? Just shout, what is Peters anomaly?
It's a corneal dysplasia.
Corneal opacification. So what's the difference with what kind of opacity? With the iris? Without the iris you can't have Peters anomaly? Oh, so you can have with or without? Or there can be posterior defect. So do you see what I mean? We're using one diagnosis for all these different types. How is that accurate? How is that accurate? So here we are. This child has some iridocorneal adhesions. He was sent to me from California, and we did the visual evoked potentials that showed that one eye is seeing better than the other eye. So I decided that I was going to do selective endothelial removal. This is how you do it. You use low aspiration, 20 millimeters of mercury, and with the OCT, I know that I'm not damaging decimase. I am aspirating the diseased endothelium, and you'll see that I go into a little bit into the clear cornea. Why? Because you want to get rid of the barrier that's stopping the healthy endothelium from growing into the diseased endothelium. So low aspiration, some people use a silicon tip, that's fine, but low aspiration, and at the same time, in this case, I did an optical iridectomy. So I've taken the optical iridectomy. Oops, I've gone forward too much. So that's what I did. I always do an optical iridectomy with selective endothelial removal to speed up the visual rehabilitation. The mother doesn't live close to me, so she sent me these pictures, and you can see from, so remember this is written in American, right? So 9th is September, and 12 is December, right? We do this month first. For over 3 months, look how much it cleared. Now, in this case, you cannot do selective endothelial removal because there's an excavation and decimase is gone. If you try to do selective endothelial removal, you're going to damage the cornea and you're going to get a big opacity. So do you see how the phenotype determines what you can do. When you say Peters anomaly, it's like, look, at the moment, there's a cough. Now, I know it's just a simple cough, but if you say somebody's got a cough and that's the diagnosis, they could have a cough for any reason. And the treatment changes with the reason for the cough. So if we don't change our terminology, then continue to get everything wrong. So in this case, I did penetrating keratoplasty. And in the last follow-up is visions 2070 for near, both eyes open, 2070 for distance, 2040 for near. Okay, the last one is when you have glaucoma and ectasia, I do something called a sandwich technique. So as you remove the diseased tissue, you close it again with an 8O nylon. Why? Because you don't want an expulsive, all right? Your end-tidal CO2 should be 30, and you give mannitol. You really want to make the eye soft. Now you are going to lose some endothelial cells, but lots of visco, and you put the new graft over. And once you have done that, you cut the 8O nylon on the host, and you pull it out. And that way, the eye is always closed. It's called the sandwich technique, and it's a technique I use when the glaucoma has been bad and there's ectasia, because I do not want an expulsive hemorrhage. So, on that note, I was asked to talk about advanced techniques. Don't be afraid. If you would like to learn these techniques or become part of the International Congenital Cornea Network, please scan the QR code. There's a registration form. Join, and we will be having a virtual meeting in June. We already have 472 people across the world who believe that these children who are born with congenital corneal opacities need more care than we are presently giving them. Thank you.
Thank you. Great job. Any questions? We have probably time for one or two. That was an excellent talk, by the way. That was the first time I've seen the sandwich technique. I think that's ingenious.
It wasn't my idea. It's been published by another group.
I think that's ingenious.
It's a very helpful group, but you have to accept that you're going to lose some endothelial cells, but
yeah.
it's better to lose those than the eye.